Yes.
Hello, good afternoon.
DP World. Thank you once again for making time to join this important program. If you remember, I think about 2 weeks ago or about 3 weeks ago, there was a publication indicating that the number of diabetes-related complications in our teaching hospitals, have escalated. And as a company or organization, we are always in there to provide solution, partnering with key experts, cardiologists, nephrologists, to resolve or to chart a path to help these patients in terms of managing their conditions, as well as preventing some of the complications associated with the disease. This afternoon program, we have two of our key experts. One of them whom you know, in fact, two of them, you know variably all of them. So I want to take the opportunity to introduce them shortly because of the time. One of our first speaker is Dr. Mrs. Pedita Ochri. She's a consultant nephrologist and a lead nephrologist at Confanoche Teaching Hospital. She's also the unit head, let me put it that way, and a senior lecturer at the Kwame Nkrumah University of Science and Technology Medical School. She will give us the first presentation, and then our second presentation will be done or will be taken by Professor Vincent Boima of Kolebu Teaching Hospital. He's also a lead nephrologist in Kolebu Teaching Hospital. He wears double hat as a head of the unit. There's a nephrologist and the head of department. He's also a consultant nephrologist and a senior lecturer at the medical school, University of Ghana. At this moment, I would like to invite Dr. Mrs. Pedita Ochri to take us through the first presentation. Viewers, just fasten your belt and give her your maximum attention. Thank you very much.
Good afternoon, everyone, and I'm happy to be involved in this afternoon's presentation. I'll thank everybody and then also thank the organizers for this afternoon program. My topic this afternoon is why early intervention is key to save the kidneys, the role of the primary care physician. Why early intervention is key to save the kidneys, the role of the primary care physician. So we will look at this outline. There'll be a case presentation. We'll look at the burden of chronic kidney disease, then how to define chronic kidney disease classification, the causes and risk factors, and how to diagnose chronic kidney disease and the treatment options available for chronic kidney disease. So starting with the case presentation, this is a patient that has a risk of cardio-renal disease. So I'll just give a background of the case and then we'll go through the rest of the presentation and later we will address it. So this is a 68-year-old man with a type 2 diabetes for the past 10 years. He weighs 135 kilograms and the body mass index is 31.8. He's on metformin 500 milligrams twice a day. He takes gliclazide 40 milligrams twice a day, atorvastatin 20 milligrams daily, and then comes for review annually. Blood pressure is 155/95 millimeters of mercury. So his current EGFR, estimated glomerular filtration rate, is 78 mL per minute per 1.73 meters square surface area. But a year ago, the EGFR was 80. And the urine albumin creatinine ratio is 76 now, and a year ago it was 35. So we have to try and put these figures in our mind. His hemoglobin A1C is 72. So what do we know about chronic kidney disease in Ghana? Well, before that, we are saying that the prevalence of chronic kidney disease in sub-Saharan Africa is 13.9%, and in Ghana is 13.3%. So roughly, it's like 1 in 8 people. When you take 8 people, one of them will have chronic kidney disease. And we all know that it affects the working group. So the average age is between 46 to 55 in Ghana. And the common risk factors we know is hypertension, chronic glomerulonephritis, and diabetes in Ghana from some studies that have been done. Globally, what is the picture? Like Ghana, I said it's 1 in 8, 1 in 7. The whole world is 1 in 10. And an estimated people of 850 million have chronic kidney disease, and nearly 90% of these people do not know that they have the condition. So it makes the picture very serious. If you have about 800 million or 850 million people, and 90% of these people, they don't know that they have chronic kidney disease, and it's something that we should be worried about. And commonly, we all know that diabetes, hypertension is the leading cause of chronic kidney disease globally. If you have chronic kidney disease, we should be concerned again because it increases hospitalizations and then healthcare resource utilization. So we should be worried about it. Why again should we be worried about it? Because if you have your estimated glomerular filtration rate reduced and your urine albumin also increase, then your risk of dying from cardiovascular diseases is very high, and then your risk of developing to let's say end-stage kidney disease is also very high, and therefore we should be worried. If even your only this diagram is showing that just EGFR alone, they have independent risk factor. If you have low EGFR, your risk of dying from cardiovascular events is higher. If you have high urine albumin creatinine ratio, your risk of cardiovascular event is also high independently, and together it will compound the risk of cardiovascular events. And then the second graph also is giving us a picture of kidney events, like going on dialysis and having maybe kidney transplant. So when you see these markers, when you see that your albumin creatinine ratio is increasing, it's a cause to be worried. When you see that your EGFR is also reducing, it's a call for us to be worried about. Again, chronic kidney disease is associated with morbidity and high inpatient care. This is well-established fact, and everybody knows this, that once you have chronic kidney disease, your mortality goes up, morbidity goes up, and then in and out of hospital is also up. Chronic kidney disease, how do we define it? When you have a pathological damage to your kidneys, or you have a markers of damage in your blood or urine that has lasted for more than 3 months, or you have a EGFR, you've done somebody's kidney function today, you repeat it within 3 months' time, and it's persistently less than 60 mL per minute per 1.73 meters surface area. So these are the definition. You cannot just take one time EGFR and tell somebody that you have chronic kidney disease. No, there should be that fact established that it has been there for more than 3 months. The risk factors, they are not new to us. Hypertension, diabetes, somebody with cardiovascular disease. If you have a family history of hypertension, diabetes, cardiovascular disease, also put you at risk of chronic kidney disease. And if you have some systemic diseases like maybe SLE, or you have somebody that have had acute kidney injury injury before, you are at risk. If you take unprescribed medications that are toxic to the kidneys, you may also be at risk. And as you grow, though age is not a disease, but as you grow, even there's a natural decline of your EGFR, and it may put you at risk, plus other diseases that the person may have. This I have said it already. The common causes, you have type 2 diabetes, glomerulonephritis are chronic infections that affect the kidneys, hypertension, polycystic kidney disease, and other vascular diseases. And when you get chronic kidney disease, we have established that the fear is that you may develop end-stage kidney disease, and therefore you may have to go on dialysis. Dialysis has its own issues. Transplant has its own issue, getting donors, the money involved, even accessibility. Now Ghana is trying to do, but we haven't reached there. So all these are cause for us to be worried. And most of our patients, even they will develop cardiovascular events and die before they go on to end-stage kidney disease. Now, the classification of chronic kidney disease have been modified. In the past, we just was classifying it based on your estimated glomerular filtration rate, but now we combine that one with your urine albumin creatinine ratio. So always when you see a patient, apart from you getting the serum creatinine, albumin, and then calculating the EGFR, you need to do the urine albumin creatinine ratio as well, and then you combine them. So if you combine them now, you don't just say you are in stage 1. If it's stage 1, there's a spectrum of the stage 1 based on your albumin and urine albumin creatinine ratio. So if you see here, the A1, when you're depending on the units that you are using, if it's milligram per millimole, then you are saying it's 3. If it's milligram per gram, then you are using the figure of 30. So depending on where you are, either less than 30 or between 3 and 30 or above 30, or less than 30 milligram per gram, or between 30 to 300 milligram per gram, or above 300 milligram per gram, then you know you are A1, A2, or A3. And then you combine your estimated glomerular filtration rate. So you can get G1. Somebody may be in stage 1, but the albumin creatinine ratio may be within 30 to 300 milligram per grams, and therefore that person will be G1 and A2. And so that is how now the classification has moved. So don't just do classification based on the estimated glomerular filtration rate. This one, I think I have spoken about it before. So how will you investigate or make a diagnosis? From your history, physical examination as medics that we know. The basic test that you know you have to do is your serum creatinine. That will help you to get the estimated glomerular filtration rate. And then when you just Google, you get the MDRD calculator, then you put in the figures, then you calculate the EGFR, and then your urine test to also get the albumin creatinine ratio, so that with the two together, then you stage the patient. And then you may also need ultrasound to rule out other causes of the chronic kidney disease. You may have to do, if it's a man, you may have to do the prostatic specific antigen, and then you may do protein electrophoresis. So history is very important, because history will guide you to know what is the cause, and it will let you know the specific investigation that you are supposed to do. But the first one, the serum creatinine and the urine parameters, that one, once the patient has a kidney issue, you should do it for everybody. And based on the cause, then you tailor the other investigations that you want to do. That's how come you may want to do the viral serologies, BFC, HIV. You may want to do antibodies like double-stranded DNA and anchor tests. So depending on which disease you are expecting. And then you may also want to do a kidney biopsy as well, depending on the history and then physical examination. And then how often do you screen individuals who are considered to be at risk for chronic kidney disease? So the initiation and frequency should be individualized based on the patient in front of you, the risk factors that that patient has, then you can say that this one I'm going to do once a year, twice a year, or 3 times a year. So this curve is showing us what happens with the kidneys. If the natural aging, as you grow, that is naturally your EGFR by a year may fall by 1. So naturally, as you age, your EGFR will go down. And then, but if you have a chronic kidney disease as well, and then you don't do anything about it, you see the slope, the way it falls. So this tells us that if somebody has a chronic kidney disease, something should be done about it. If you just leave it, then the patient will just drop easily to end stage, and then we'll have all the cardiovascular events and then the other things that we are worried about. So what are the framework for treating chronic kidney disease as at now? You consider if there is any underlying cause of the chronic kidney disease, then you deal with it. So I always have to look for what is causing the chronic kidney disease. Then you stage it by using the estimated glomerular filtration rate and the urine albumin creatinine ratio. And sometimes you may also want to calculate the 5-year and then 2-year risk of kidney failure as well. And then you initiate appropriate lifestyle changes. So exercise, weight loss, salt intake, foods. So all these lifestyle changes, stop smoking, moderate consumption of alcohol should be factored into the patient's management. And then you focus on blood pressure and diabetes management if the patient has hypertension and the patient is also a diabetic as well. And then the role of statins. Statins also have a role in stages 3 to 5 to reduce your cardiovascular risk. And then if that patient is a patient that will need vaccines, you may also have to offer them the appropriate vaccines. And then the drugs that you want to focus on maybe to reduce their blood pressure will be ACO, ARBs, we have the SGLT2, and then we have the mineralocorticoid antagonists for cardio-renal protection. Then you monitor the patient, like I said, depending on the patient that you have in front of you, then you determine the frequency that you should monitor. Then you prepare for dialysis or kidney transplant when the end stage happens, the inevitable. Okay, so slowing down the progression of chronic kidney disease. Realize that the slope, the way it falls, if you treat, if you put in interventions, then you are able to reduce the slope from the way that it falls. So it's very good that we have to introduce appropriate intervention so that the patient may not end up in end stage. You can always prolong delay. You can keep the patient in one stage for a very long time based on the interventions that you put the patient on. And then the other preventive measures that you may have to, so healthy diets, adequate hydration, and then physical activity, which we have spoken about, weight control, tobacco, nephrotoxins that we need to also avoid. When we say nephrotoxin, don't let your mind just go on to herbal medicine. Within the orthodox medicine that we use as medics and paramedics, look at the medications that can be also nephrotoxins and then try and then avoid. And some of them you may adjust the frequency and the dose. And then you screen for genetic diseases as well, like polycystic kidney disease or apolipoprotein mediated chronic kidney disease. Then you manage the risk factors, the obvious ones that we all know, your hypertension, diabetes, if there's prior AKI, if there's any systemic disease like retroviral infection, SLE, you have to deal with that. And then the drugs, the over-the-counter medication, drugs that have not been prescribed by the analgesics, we need to be careful with those medications. We should be worried again, worried because the patient, if you don't adjust your CKD or if you don't put in intervention, ultimately this will be the final way for most of the patients that we see in Ghana. We don't have a lot of transplant. Our transplant program is new. is new, and therefore most of our patients are on dialysis. And we all know that even dialysis is recently that it's been subsidized. It's not all centers. So we have to put in good intervention so that we spare our patients from going on to dialysis for a long time. So we come back to the case that we saw. So we want to address the risk factors of this patient. We realize that he's an elderly man and has type 2 diabetes for 10 years. And we all know that if you have type 2 diabetes, it is being said that the day that you are being diagnosed, you may have kidney problem, you may have eye problem already. So the moment you diagnose somebody with a type 2 diabetes, please, 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 as a family care physician, what is your role? Your role is to do the urine dipstick number 1, and then do your albumin creatinine ratio, and then do your creatinine, and then estimate the eGFR. If you see a patient for the first time, you do this. If it's normal, monitor within 3 months, within 4 months. You do again. If there's any change, you can catch them early. Another risk factor for this patient, realize that his BP is not too good, well controlled. That is it. If you just saw this, the eGFR, you see that it's 78. You say, oh, this one is normal. But a year ago, you realize that it was 80. So it means that something is happening to this patient. And then the albumin creatinine ratio, a year ago, it was 35. And now it is what, 70. You get it? So when you see patients, just get these values down and then put in the appropriate interventions to bring them down. So how do we manage these patients that we have seen? Lifestyle changes will play a role. We have to make sure that we control the blood pressure very well. Glycemic control is very necessary. And then our renal protective agents, agents that are good for the heart, agents that are good for the kidney, to slow down the progressions. Some of them ACARB, the SGLT2 inhibitors, and the mineralocorticoid receptor antagonists. There are others to that. For the sake of this, I will not go there. So when you do this, you'll be able to change the slope to delay what? The development of end-stage kidney disease in patients like our patient that we have described. Again, these are KDIGO guidelines, and all of them. So for KDIGO, they are saying that first line, you see the lifestyle modifications they are here. If the patient especially is said, this is diabetes with CKD, lifestyle is there. Then your first line medications, you realize that the KDIGO is saying metformin, RAS blockade, statins, and the SGLT2 is there as a lifestyle. Then you move on to other interventions if the patient is not doing well. So I will end here for subsequent presenter to continue. And if there's any question, I'll love to take them. Thank you very much.
Thank you very much, Dr. Mrs. Pedita Ochri. This is quite insightful. I'm really grateful for that. We want to quickly move to our second presenter, who is the person of Professor Boyuma. He'll be talking on the cardio-renal benefit of empagliflozin in the EMPA-KIDNEY trial, the final piece of the puzzle. Please don't, get up, further fasten your belt and listen to this great professor. Thank you very much. Professor Boyuma, your audience, please.
Sorry, my slide is not projecting. Okay, finally. So good evening, everyone, and thank you for coming for this presentation. And thank you, Dr. Ochri, for setting the stage for this presentation. So here we are looking at cardio-renal benefits of SGLT2 inhibitors with emphasis on empagliflozin. So this will be my disclosures, and my outline for the day is as stated. So as Dr. Ochri already stated, About 1 in 10 million adults worldwide have kidney disease, estimated at 850 million people worldwide having kidney disease. As a result, this has been referred to as being a hidden epidemic that is really occurring, with an estimated excess mortality rate of around 47%, meaning that almost 5 to 10 million people die annually from CKD. And the other burden that CKD poses to the health system is increased hospitalization, healthcare utilization, of course, strain on the dialysis and other infrastructure, of even on families, bringing in on families catastrophic household expenses on healthcare, on dialysis, on kidney replacement therapy, etc. In high and middle income countries, as Dr. Autry said earlier on, diabetes and hypertension seems to be leading causes, but in our part of the world as well, we need to identify ourselves with causes that probably are specific to our environment, which could be nephrotoxin exposures from herpes, from NSAIDs, from other infections like Hep B, Hep C, family history of kidney disease, among others, are things. In fact, glomerulonephritis or inflammation in the kidney should be something that we look at also in our part of the world. Genetic predisposition to kidney disease is something that we need to look at as well in our part of the world. So by way of definition, the chronic kidney disease is abnormalities usually in structure and function of the kidney that persist beyond 3 months, and defined by eGFR or glomerular filtration rate of less than 60 ml per minute, perhaps that have been persistent for at least 3 months or more, or abnormal levels of protein in the urine of more than 30 milligrams per gram, again persisting for 3 months or more. If you look to my right, you see a way in which CKD is now classified, as Dr. Autry spoke about earlier on. But you look at levels A2, A1, A2, and A3, and the GFR criteria. And if you look at those with GFRs above 60 with little or no protein in the urine, that falls into the green zone. And these people, you can't label them as kidney disease. However, you still need to keep them in the back of your mind if these are people who may be at risk of progression. For instance, if they have diabetes, hypertension, family history of kidney disease, etc. This will still need some defined way of monitoring, which you need to keep your eyes on even in your clinic. But even within that GFR range, which is probably relatively high levels of GFR, once they begin having protein in the urine from 3 to 30 milligrams per millimole, even to high levels of protein of more than 30 milligrams per millimole, they are still at risk of progression to kidney failure, at risk of cardiovascular disease for that matter, and requires monitoring, requires early detection for timely intervention to delay progression of kidney disease, and then also decrease the risk of cardiovascular disease. Again, once the GFR is below 60, as you can see, again, there's a high risk of progression, high risk of cardiovascular disease, as you can see on the table or the heat map in front of you. So early detection, timely intervention in the early stages is key to keeping these people off dialysis or kidney transplantation in a long time before they begin even needing it in future. As Dr. Autry stated earlier on, independently, low levels of GFR or proteinuria predict high risk of cardiovascular death even among patients with chronic kidney disease. So when you look at this graph carefully, those with GFRs of below 60 independently would increase the risk of cardiovascular death, as you can see, compared to those with GFRs of around 90. Again, when you look at the proteinuria, high levels of proteinuria compared to low levels also do increase the risk of cardiovascular death among these patients. A combination of both even heightens this risk of dying from cardiovascular disease, against emphasizing the need to detect this very early in mild to moderate ranges of proteinuria, or very healthy levels of GFR and institute timely management that can delay the progression of kidney disease. Again, as your GFR falls, the risk of progression in cardiovascular disease, as I said earlier on, is high. And as your protein increases, there's a risk of kidney failure also occurring. So again, emphasizing the need for early detection, the need for evaluation of all these people that attend our hypertension, diabetic clinics, detecting the kidney disease early, intervening with guideline-directed medications that can slow the progression of kidney disease. And once you have kidney disease, there's a significant high risk of morbidity, mortality, and a risk of inpatient care compared to people who don't have CKD. So, for instance, compare people with any stage of CKD to people who don't have CKD. They are at 4 times risk of being hospitalized for inpatient care compared to those who don't have CKD at all. And if you have advanced stage of CKD, for instance, that your risk of being hospitalized 12 times the person who has no CKD, and that also heightens your risk of morbidity and eventually mortality. So there's a need again for us to pick up these people very early and then also institute timely interventions that can really reduce the risk of inpatient care, morbidity, mortality among this cohort of patients. When we look at the whole spectrum of CKD, that's cardio-kidney-metabolic syndrome, you break the components down one by one. Each of these components can actually reduce patients' lifestyle. For instance, take BMI alone, that can reduce the lifespan by almost 8 to 10 years. Diabetes reduces that lifespan by 13 to 14 years. And when you do have advanced stage kidney disease, it reduces your life expectancy by more than 20 years. And look at the component. There was a survey in the US which actually studied the various components of the CKM syndrome and their risk of mortality. And they found out that the components are actually produce a synergistic increase in mortality risk. And the 10-year survival shows that diabetes alone, actually, when you have diabetes alone, your risk of mortality is 7.7%. When you have CKD, that risk is 11.5%. But when you have a combination of CKD and diabetes, that risk exponentially rises to 31.1%. So the more of the components of CKM syndrome you have, the more your risk of dying, the more your risk of having complications. There's an interconnection between the heart disease and also the kidney disease in these patients or in the CKM syndrome. The same risk factors that give rise to the kidney disease are the same risk factors that really give rise to the heart disease, so the diabetes, the smoking, obesity, hypertension, dyslipidemia, genetic risk factors, acquired risk factors, all increase the risk of either heart disease or the kidney disease. So once you see these patients, with patients with CKD, you have to screen for or evaluate them for heart disease. And you see patients with heart disease, on the other hand, you have to evaluate them also for CKD or renal function or renal dysfunction. And this will help us in our choice of medications that will benefit them in the long-term management. And also, of course, risk profile, all of them. You don't have diabetes, obesity, hypertension, dyslipidemia, etc. All this will inform the way we make choices regarding their medication, regarding their holistic management in the long term. So kidney disease is highly prevalent in Africa, and that's one more reason why we really need to evaluate our patients who are attending our chronic disease clinics, hypertension clinic, diabetic clinic, etc. The rate is as high as 15.8% in Africa and as high as 13.9% in sub-Saharan Africa. Therefore, we need to look out for these patients and institute timely management that would keep them off dialysis or kidney transplant for a long time. Sadly, these patients are very young and represent the productive group of our society. Look at this graph, for instance, from Ghana, the Ghana registry. Most of our patients are between the ages of 20 to 55, 60 years, and these are economically productive people who should be out there working, who are actually being held down, afflicted by this disease, and therefore they lose time at work, they probably lose their job, or they cease being breadwinners of their family, etc. And it's important for us to keep these people out there working in one way or the other by instituting preventive measures or early detection to delay progression and keep them productive in society. When you compare these graphs to the one on my right, you see is a graph from the UK, and most of the patients who are on dialysis are actually above the age of 60 years. And that means that our people tend to develop kidney disease some 20 to 30 years earlier compared to people in Europe in other parts of the world. And that should be some reason why our people perhaps are developing kidney disease earlier. Could be genetic, could be environmental factors, whatever it may be. What is important now is to pick them early and give them the appropriate treatment. So right in utero, before we are born, we may have some exposure. So we are born again, we are exposed to all kinds of individual comorbid conditions, social determinants, and environmental exposures, all of which can increase our risk of cardio-kidney-metabolic syndrome. However, we have an opportunity even before an incident, CKM syndrome, to put in lifestyle measures that can delay or actually prevent the development of CKM. So we can exercise regularly, eat healthy, lose weight, check BP regularly to detect it early and treat, or if we already diagnosed, take our medication to make sure they are controlled, and check our sugar regularly to make sure we detect it early and treat. And if we are diagnosed, take our medication to make sure we control the sugar to target. These are key in prevention of CKM syndrome. However, if an incident CKM syndrome develops, we do have an opportunity to timely intervene with guideline-directed medications that will slow progression or delay the disease. So we could also use drugs which have evidence for protection of kidney disease, ACE inhibitors, ARBs, SGLT2 inhibitors, GLP-1 receptor agonists, non-steroidal MRAs, etc., to actually reduce our risk of developing kidney disease, delay development of kidney disease, or delay progression of kidney disease, and prevent or decrease mortality in our patients. So that's calls for timely strategies by way of early detection. So there's a need for early detection and early treatment to delay progression of this patient. In 2024, KDIGO Clinical Practice Guidelines emphasizes the management of CKD patients and our patients. Wow, sorry, apologies. There's something going on here. Sorry, can I be helped? My slides are not moving.
You can be heard, Prof, and your slides are also moving.
Okay, they are moving now. Okay, thank you. I'm stuck here. Actually, I can't see my own slide moving. Okay, I think it's moving now. Wow. Okay.
Okay.
Okay, so as I said earlier on, there's a need for us to detect this early. So going through the KDIGO guideline, there's a need for us to identify those at risk of CKD. So do they have hypertension, diabetes, cardiovascular disease, including heart failure, or prior history of acute kidney injury or acute kidney disease? If they do have, you test for the glomerular filtration rate, you test for protein in the urine using the albumin creatinine ratio, or other markers of kidney damage. If the GFR is less than 60 or ACR more than 30 milligram per millimole, and they have other markers of kidney damage as well, you may have to exclude AKI or acute kidney injury all the time. But if you do have these levels of GFR and protein, you'll probably sometimes want to confirm this again by doing the creatinine cystatin C GFR. And once that is confirmed, then you stage the patient or risk profile the patient according to the table I showed you earlier on, the classification table. So classify based on or stage based on the GFR and ACR, which will tell you their risk of progression, their risk of cardiovascular disease, and that would inform your choice of medications to really delay progression or decrease their risk of cardiovascular mortality. And if you don't have GFR within this range or significant proteinuria, and you think they are still at risk of kidney disease progression by risk of their comorbid conditions, in terms of their comorbid conditions or their risk factors that they may have, then you may need to arrange a long-term follow-up for them in the clinic so you can keep an eye on them. So, for instance, if somebody you risk profile the patients based on this particular table I have in front of me, how often should you follow them up or monitor them at the clinic? They're in the green box. As you can see here, GFR above 60, little or no protein in the urine. You can screen them once a year. But if they do have other risk factors like diabetes, for instance, that may change depending on how well controlled the diabetes may be, or if they have hypertension, how well controlled may be. So you may have to individualize the follow-up or monitoring as well, not just limiting it to this table. However, if everything is stable, you may screen them once a year, and they have mild to moderate proteinuria once a year, but once they have severe proteinuria, 3 times a year is recommended. Those with GFR about 45 to 59 with no protein in the urine, you can screen them, treat them all right, but monitor them at least 1 to 2 times a year. And those who have moderately raised proteinuria 2 times a year, you can see all the way through the red box, the monitoring is between at least 1 to 4 times a year based on the level of the GFR and based on the level of the proteinuria as you risk profile them, and then also use this decision to make treatment. Decision to make treatment recommendations for your patients. So once you determine the risk profile of your patients, you treat based on guideline-directed medication use in order to delay progression of the patient. So as recommended by KDIGO in 2024, if your patients do have type 2 diabetes, CKD, at least GFR of 20 and above, they are qualified to have some of these particular evidence slow down progression of kidney disease, and one of which is the SGLT2 inhibitors. And once you initiate it, you can continue this medication even if the GFR falls below 20. You may only withhold this medication when the patient is prolonged fasting, or going for surgery, or is critically ill, or had a medical illness. And because this may increase their risk of ketoacidosis, that's the reason why you may need to withhold until they are okay or they have recovered from the illness before you reintroduce your medication. Sorry, again. So the indications for using these drugs include: 1, if the person has GFR at least 20 and above, or ACR at least more than 200 milligrams per gram, or maybe even if they have heart failure. Once they have heart failure, there's an indication for using this drug irrespective of the level of their albuminuria. They can have this drug because of the overwhelming evidence in terms of the cardiac protection or the cardioprotection benefits that they have. If you start the medication, it doesn't really alter the frequency at which you monitor these patients. You can monitor them at the way it's recommended for them to be followed up, or the way you have individualized their follow-up in your clinic. And remember that if you start this drug, there may be a dip in the GFR, but that is not a reason for actually stopping the drug. You can continue medication because the dip is expected, and I'll explain to you very soon why these dips occur. And it's bound to occur when you start them, but in the long term, they tend to maintain your GFR compared to when they are not on this medication. So it's suggested that adults with at least GFR about 40 up to 45, of UCR even less than 20, so that quite so less than 200 milligrams per gram could also benefit from this medication. And if you look at the KDIGO guidelines Dr. Autry pointed out earlier on, healthy living is recommended. So healthy diet, as I mentioned earlier on, physical activity, stop smoking, and weight management are very key to the management of our patients to slow down progression of kidney disease. However, recommended is the SGLT2 inhibitors, the ACE inhibitors, as first-line medication for renal protection, for kidney protection, to slow down progression of kidney disease in the long term. But when you start this with medication, also know that you need to optimize glycemic control, or you may need to optimize glycemic control with other medication, which may include a GLP-1 receptor agonist and others, for instance. And of course, you need to optimize your blood pressure control with the use of ACE inhibitors, ARBs, or non-steroidal MRAs as well. And of course, other medications may be necessary, and the BP is not on target for you to control the BP, as this is also very important to slow progression of kidney disease. Our patients are very much at risk of heart disease, atherosclerotic cardiovascular disease as well. So there's a need for them. There may be a need for them for using statins, which they may benefit from in terms of their cardiovascular protection as well, or ezetimibe or PCSK9 inhibitors may all be drugs that perhaps may inure to the benefit of this patient when used, when risk profiled and these things are picked, and timely intervention decision is made to actually start this medication. Note that they also do carry bone disease, anemia, acidosis, and electrolyte problems that have to be treated as well. So based on this and other evidence, KDIGO recommended that these SGLT2 inhibitors and ARBs or ACE inhibitors may be used as first-line medication in patients with CKD due to their strong evidence based on delaying progression of CKD. And of course, like I said, individualized based on BP lowering. There was a consensus working group involving the European Renal Association, European Renal Care, European Renal Best Practice, and also European Renal Association, European Renal and Cardiovascular Medicine Group, consensus working group came together and they all agreed on the cardiovascular protective benefit of SGLT2 inhibitors. So when you're on this medication, for instance, they say when you have CKD and heart failure, and to improve cardiovascular disease,
Prof, we can't hear you.
mandate. Hello, can you hear me?
Yes, now we can hear you, but we lost you the last 30 seconds.
Sorry, okay. So I was talking about a consensus group paper that suggested or also confirmed the use of SGLT2 in patients with CKD, heart failure, and type 2 diabetes. And if you have CKD and heart failure, to improve cardiovascular and kidney outcomes, DAPA and empagliflozin were recommended. And if you do have type 2 diabetes, and to improve cardiovascular and kidney outcome, again, in patients with high risk of cardiovascular disease and risk of kidney disease progression, again, DAPA and empagliflozin were recommended by this consensus group in their paper for that matter. So KDIGO, as I said earlier on, level of evidence A1A actually suggested that SGLT2 inhibitors will be useful for patients with type 2 diabetes, CKD, and any of them from GFR of 20 and above. As I mentioned earlier, I defined all this earlier. So this brings us to one of these molecules, which is the EMPA-KIDNEY trial, which was conducted in 8 countries in North America, involving US and Canada, Europe involving UK, Germany, and Italy, and then Asia, China, Japan, Malaysia were involved in a distribution of randomization. So in North American countries, about 26% of these participants were randomized, and then in Asia, just China, Malaysia, and 25%, and then also Japan 9%, and in Europe 40% of these participants were randomized into this study. So EMPA was designed to actually investigate whether empagliflozin reduces the risk of kidney disease progression or cardiovascular death in patients with CKD. It was a phase 3 randomized double-blind placebo-controlled trial. It was designed to assess the effect of EMPA on broad range of patients, about 6,600 patients with chronic kidney disease at risk of progression, including many patients who did not have diabetes, and patients with low levels of proteinuria, so that's early stage, hopefully, of kidney disease. It was randomized into 2 groups, empagliflozin 10 milligrams once daily, plus standard of care, which may be any of your drugs that you're using to treat your patient, and placebo, plus standard of care as well. And the outcomes they were looking at were kidney disease progression defined by kidney function loss, defined by sustained reduction in GFR of 40% or more from baseline, or sustained GFR levels of 10 mils per minute. And also, of course, the other kidney outcome was end-stage kidney disease, defined by the need for dialysis or kidney transplantation, and of course, death from kidney-related problems were also one of the outcomes. The other outcome was cardiovascular death among these cohorts. They also have key secondary outcomes they were looking at, which includes all-cause hospitalization, first and recurrent hospitalization, heart failure, or death from cardiovascular disease, and all-cause mortality were the other outcomes they were looking at. So their inclusion criteria include adults 18 years of age or full age as required by local regulation. So it's a full age as required by local regulation, because in some countries, the adult age is not 18 years. For New Zealand, Japan, I think it's about 19 or 20. And in some other countries like Swaziland, the adult age is around 21 years. I'm sure that's why they put full age as required by local regulation. And evidence of CKD at risk of kidney disease progression as for the last 3 months or more, as defined by GFR of between 45 to 90, UACR within the moderate to severe range of more than 200 milligrams per gram, or those one GFRs between 20, at least more than 20 by less than 45. So again, clinically appropriate doses, they should be on clinically appropriate doses of ACE inhibitors or AR-based, and they should be naive to SGLT2 inhibitors at this point. So exclusion criteria, they should also on SGLT2 inhibitors were excluded if you have type 2 diabetes and you have atherosclerotic cardiovascular disease with GFR of more than 60. That's a combination of all this. You are also excluded. Those who are on drug medication of ACE inhibitors and AR base were excluded as well. Those who are immunosuppressant for at least 3 months, the last 3 months, or any currently on 45 milligrams of prednisone were also excluded from this study. And also there's those on maintenance kidney replacement therapy like dialysis or transplant were excluded from the study as well. Polycystic kidney disease, type 1 diabetes were also excluded from the study. So the outcomes were tested as a composite outcome of kidney disease progression and cardiovascular death. And if the primary outcome is positive, then they will test for other secondary outcomes. And secondary outcomes, as I mentioned earlier, was first occurrence of heart failure or CV death, or all-cause hospitalization, first and recurrent events combined, or all-cause mortality. So again, how did they test? They tested their they planned to test their outcome even before the end of the study, which was pre-specified. So they planned that when they get to 150 participants, they will do an interim analysis. And at the time of the 150 patients, they already had about 620 primary outcomes. And our target was to have a hazard ratio of less than 0.778. That means that the event rate among those who are on the drug compared to placebo should be, the event rate among those who are on the drug should be lower than those in the placebo, giving you a hazard ratio of less than 1. And they were also looking for a similar hazard ratio for the secondary outcomes. So by March 2022, the Data Monitoring Committee recommended that they should stop the trial because of positive efficacy based on the fact that they achieved their pre-specified conditions of a hazard ratio of less than 0.77 for the primary outcome and also 0.77 for the secondary outcomes. That means that the event rate, the event rate of the primary outcome among those who are on the drug are less than those who are in the placebo group, and therefore probably have achieved their aim at this point, so they ended the study. They chose a whole range of patients with different degrees of kidney dysfunction into the study. So if you look at the heat map here, those with moderate levels of proteinuria but relatively good GFR, moderate to severe proteinuria but relatively high GFR, those with lower GFR as low as 20 but with different degrees of proteinuria were all recruited into the study. And so they randomized about 6,600 participants into either the EMPA group or the placebo group. You can see for the EMPA arm that at least 22 participants withdrew consent at 0.7%, and 9 participants were lost to follow-up. Similar events occurred in the placebo group as well. So as much as 99.1% in the EMPA group completed the study, and 99.2% in the placebo group completed the study. So final follow-up visits were completed in June 2022 with 99% completeness and a median follow-up of 2 years for this particular study. This was the general characteristics of their study, which was similar in both the placebo arm and the drug arm, to equal numbers of males and females, equal numbers of those who don't have diabetes in both arms, and those who have various types of kidney disease, from diabetic kidney disease, glomerular disease, hypertension, renovascular disease, and at different levels of GFR. At least those who had GFRs of less than 30 were about 1,000 or about equal in both groups, and those who have ACR of less than 300 again were about equal in both groups as well. So that's the general characteristics of those who participated in this study. And again, for these participants, as much as 54% had no ratio of diabetes, 27% had a history of cardiovascular disease, 48% has ACR of less than 300, which lies in the mild to moderate zone. So those were people who were picked at an early stage and probably treatment was started. And those who have GFRs lower than 30, or maybe in advanced stages of kidney disease, who were in a study, were also about 35%. And like I said, they have various underlying etiologies: diabetes, kidney disease being 31%, hypertension and vascular disease being about 22%, and others, glomerular disease being 25%. So these are people with glomerular disease who do not have diabetes or may not have hypertension, but by virtue of the kidney dysfunction and proteinuria, may be benefiting from this medication. So they were also recruited into the study. So looking at a primary composite outcome, you would see that they were less in the empagliflozin group compared to the placebo group, with 28% reduction in the rate of kidney disease progression or cardiovascular death in the EMPA group compared to the placebo group. And this has a hazard ratio of 0.72, which is less than 1. It was significant. So there's a significant difference between the two groups in favor of empagliflozin. And then we look at when we separate the components of the composite outcome, kidney disease progression again was less in the EMPA group compared to placebo group, with a hazard ratio of 0.71. So the events were less in the EMPA group compared to the placebo group, and this was again significant. And when you look at the CVDEP, even though it seemed not to be significant, but there was still events were still less in the EMPA group compared to the placebo group. So the key secondary outcomes, all-cause hospitalization first and recurrent hospitalization against, were less in the empagliflozin group compared to the placebo group, with 14% reduction in the risk of hospitalization among those who were in the empagliflozin group, with a hazard ratio again of 0.86, which is less than 1, and this was significant as well. So the key, again, secondary outcome, first adjudicated heart failure or CV death was less in the EMPA group compared to the placebo group with a hazard ratio of 0.84, less than 1. And this was, even though not significant, but still the events were less in the EMPA group when you compare these to the placebo group. A nominal reduction in the risk of 16% reduction in the risk of CV death or adjudicated heart failure compared to the placebo group. All-cause mortality again was less in the EMPA group compared to placebo group, even though this did not reach statistical significance, but it gave 13% risk of reduction in the mortality in EMPA group compared to placebo group. So if you look at this table again, telling the same story by giving you the absolute numbers, so the risk was more in the placebo group compared to the EMPA group, and heart failure again was more in the placebo group compared to the EMPA group as well. And so as you can see, summary of the efficacy results shows CV death and kidney disease progression. There's our 28% risk reduction for CV death and kidney disease progression, which was significant for those who were on the empagliflozin. And also key secondary outcomes, all-cause hospitalization, first and recurrent, where again there was 14% risk reduction in favor of empagliflozin, which was significant as well. For CV death, heart failure, all-cause mortality, even though not significant, there was still about 16% risk reduction in favor of empagliflozin compared to placebo. And this was subgroup analysis comparing, for instance, people who have diabetes or people who have no diabetes. And you realize that across all these categories, whether you have diabetes or not, there is still a benefit for those who are EMPA in terms of the primary endpoint of kidney disease progression and CV death, which was more common in placebo compared to those on the drug. And for those various levels of GFR as well, you see there was significant difference between the placebo and those who are on EMPA as well. So as early as more than 45, GFR more than 45, we were without proteinuria, there is benefit. And as late as GFR of less than 30, there's also some benefit in terms of using this drug. And we look at the proteinuria level, it was significant for those who have at least severe levels of proteinuria and who are on this medication. They benefited in terms of decrease in the risk of kidney disease progression, also reduction in the risk of cardiovascular death as well. So when you look again, subgroup analysis for primary key points across all age groups, there was some degree, or generally you may say there's some benefit for those less than 60 years and those more than 70 years. So across age groups, still there's some benefit in favor of EMPA compared to placebo. Male, female, there were benefits. So irrespective of gender, there is benefit. Irrespective of race, generally, you may say there's benefit as well, particularly for those from Japan, Europe, China, Malaysia, etc. But generally, across the group, there should be some benefit in terms of its use. Across the various groups of types of kidney disease, those of diabetic kidney disease, glomerular diseases benefited, and as you have hazard ratios of less than 1 and confidence intervals that show significant difference between the placebo and EMPA, and with EMPA benefit in terms of less events compared to the placebo group, as compared to hypertension and other causes where there seem not to be any benefit there. Across the various levels of glycemia as well, when you look at the glycated hemoglobin, there seems to be significant benefit in favor of empagliflozin compared to placebo. And whether you have CV disease or not, you still have benefit, as you can see over here. And whether it doesn't matter whether you're RAS or no RAS. And in fact, even those who are on RAS actually tend to benefit more than those who were on RAS. So there is some benefit even when you're on RAS, and you add this drug on top, you see they have a reduction in kidney disease progression and CV death. So all-cause hospitalization again has similar trend across all the subcategories earlier on, and then it's we look at GFR decrease over time. When you initiate the drug, like I said earlier on, there will always be some dip in the level of the GFR. But when you watch the trend over time, you see that the GFR stabilizes in a long term. Whereas when you compare that to placebo, there's a gradual decline in the level of the kidney function over time. So this initial dip should not be the reason for stopping the medication. We should continue the medication for its overwhelming benefit that the patient will derive in the long term. One of the reasons, or maybe there are many postulated reasons for this dip, which may be the fact that there's inhibition of glucose reabsorption at the proximal convoluted tubule. So there's increased delivery of solute, for that matter, to the distal convoluted tubule, which actually would is a signal to stimulate the macula densa and stimulate or trigger a tubulo-glomerular feedback, for that matter, which would trigger other hormones and cause vasoconstriction, which would actually decrease eventually the intraglomerular pressure. And this decrease in intraglomerular pressure or intraglomerular hypertension may be a reason why the GFR is dipping. That in itself may be healthy, because in CKD patients there is increased glomerular pressure. There's what we call glomerular hypertension, which may worsen kidney function. So decreasing it is a good thing. But though you may see the effect as a dip in GFR, like I told you, in the long term, it stabilizes. And of course, we know that there's a risk of AKI, but we know that when AKI occurs, we look for other causes of AKI, even before we think that it is probably the SGLT2 inhibitors, which may be causing the AKI. So annual rate of change in GFR, like I mentioned earlier on, you see the difference between the EMPA group and also the placebo group. Irrespective of diabetes status, there's a significant difference between the two, especially those who, especially for the diabetes group. There is a difference in terms of slowing progression of kidney disease, which is more so in the EMPA group. When you look at the GF across various levels of GFR as well, there is also a significant difference for those who have GFR at least in the early stages of more than 45 here. So timely detection very early may actually be really very beneficial for this people. It's important for us to pick them up early, to this medication that will really inure to their benefit. Again, for high levels of proteinuria, you may see that benefit also occurring. Overall, there is a significant benefit in terms of the difference in slowing down progression of kidney disease, which is in favor of empagliflozin. So a summary of other secondary outcomes, I mentioned this earlier: kidney disease progression, CV death, progression to end-stage kidney disease. There were relatively more events in the placebo group compared to empagliflozin group. And then irrespective of the underlying cause of kidney disease, there's still some benefit. So whether there's kidney disease progression by way of being on dialysis, progression to dialysis, or having sustained GFR of less than 10, we still have more events in the placebo group relatively compared to those in the EMPA group. There was no difference in terms of death from renal disease between the two groups, and for progression to being on dialysis, GFR of less than 10, we still have more events in the placebo group compared to the EMPA group. Sustained GFR decline of more than 40 from baseline. We have more people in the placebo group having it compared to those in the EMPA group. Any kidney disease progression at all occurred more in the placebo group compared to the EMPA group as well. And so overall, the safety in terms of serious adverse event, no serious adverse events. Therefore, serious adverse events, there seems to be more in the placebo group compared to the EMPA group. And for all the other side effects that we expect, there was no significant difference when you look at the confidence intervals. For all of them, there was really no significant difference: UTI, ketosis, dehydration, hyperkalemia, serious AKI, bone fracture, severe hypoglycemia. There was no significant difference between the two groups. Again, for all other infections that were studied, when I look at the confidence interval, you see that there was no clear significant difference between the two groups. So any reason for stopping any serious adverse event, any non-serious adverse event, etc., there was no real difference between the two groups as well. So in evaluating our patients, it's very important for us to assess their medication all the time. Assessing the dosage and the regimen are really very important. Assess if the regimen are correct, if the doses are correct. Optimize the medication impact by evaluating whether each medication is necessary or whether any other necessary medication is needed for kidney protection in the long term, for cardiovascular protection in the long term. Determine whether each medication is the preferred medication for the patients you are looking after. Resolving any discrepancies, and I've said all the time that there's always a discrepancy between what the patient is telling you in terms of the medication is he or she is taking and what is written in the records. So we always need to compare the two groups and reconcile the medication, reconcile the instructions, reconcile the reasons why you are changing medication or modifying the patient medication, so they understand when they are going home, they'll be more confident in taking this thing without not consulting anybody else who may end up confusing them. And then also minimize the medication-related problems. Review the medication list for interaction or adverse event, ensuring the proper monitoring takes place all the time. Assess medication adherence and causes of non-adherence. Obtaining an accurate medication list all the time, each time you review them, and make sure the medications they have are the same as what is in your record and it agrees. And always get a feedback for your physicians who refer these patients to you, so the two of you would be on the same page all the time. Otherwise, when it goes back and the primary care physician decides that, oh, okay, you shouldn't be on this medication, perhaps it is because we haven't communicated to them. But if we tell them why the patient has to be on a medicine A or B, maybe we will all be on the same page and discuss with them whether, if even at this GFR level, this decreased amount of GFR, is it safe for them to be on the medication. We need to discuss all this with them. So at the end of the day, we all remain on the same page when we are managing our patients. So it is important to the risk profile of our patient, determine whether they need these medications, put them on the medication that they may benefit them, very important. Assess adverse events, very important. Assess the potential for contraindication, sick day off, as I mentioned earlier on. Assess their risk of hypoglycemia, and perhaps stop other medications that increase their risk of hypoglycemia, like the sulfonylureas, etc., and then bring on this medication that probably may benefit them even more. Assess their volume status and improve their volume status, or medications that they may be taking which may also affect the GFR, end stage about medication, and encourage them to stop all these medications so you can actually be able to use your drugs to for their benefit in the long term. So in conclusion, for the primary outcome, EMPA reduced kidney disease progression or CV death by 28%. All-cause hospitalization reduced by 14%, which was significant as well. And GFR preservation was low, annual rate of decline of GFR by almost 1.37 ml per minute per year, which was also significant. And also this was efficacious across all ranges of patients, whether they have diabetes or not, irrespective of the GFR levels and irrespective of their albuminuria categories. They all had some benefit, as we discussed earlier on. And these drugs, because of their overwhelming evidence, have appeared in all our guidelines for the KDIGO 2024 guideline, strong evidence to use these inhibitors as first-line medication, SGLT2 inhibitors as first-line medication. And again, it includes other populations of patients, non-diabetics as well, glomerular disease, people with low levels of proteinuria as well, as you can see from the study, also benefited. Safety profile is well tolerated, as you can see, and healthcare economics, where it reduces the hospitalization rate and therefore may reduce cost to these patients as well in the long term. So EMPA represents a paradigm shift in CKD care from reactive dialysis preparation to proactive protection, offering hope for the 850 million people worldwide living with chronic kidney disease. EMPA, as we see already from the EMPA-CKD, is a landmark trial establishing SGLT2 inhibition as a foundational therapy for slowing CKD progression across the cardio-metabolic spectrum. As we said earlier on, all the components of this spectrum can synergistically increase mortality, can synergistically increase kidney disease progression, can synergistically increase cardiovascular disease mortality thereof, and therefore it is important for us to make timely choices that would inure to the benefit of these patients in the long term. So I'll pause here for any comments. Thank you.
Thank you so much, Professor Boima, for such an insightful presentation, and Dr. Pedita as well. Indeed, early detection and timely intervention with guideline medication is important. I'd like to just remind the audience, at the top right of your screen, you'll see the comment section. Please type your questions on the chat, and we'll be able to address that at the end of the session. Before we go to question and answer, at this point, allow me to invite Jonas to give a 1-minute presentation on the available options in the market. Thank you.
Thank you very much, Brenda. I'm actually loading my slide. I don't know what. It's a bit... All right. Thank you very much, Brenda. My name is Jonas. I think I've introduced myself already. I would like to take this opportunity to thank both Professor Boima and then Dr. Pedita Ochre for the insightful presentation. I have just a simple task just to bring to your attention once again, as an organization or a company, what do we have readily available? Well, as we are aware, in Ghana currently, we have Jardiance, which is empagliflozin. We have both the 25 milligram and then the 10 milligram available. But if you listen to the presentation carefully, you notice that if you look at the EMPA-KIDNEY data, the 10 milligram Jardiance is what is actually recommended for such purposes, or that is one of the key indications, that is the 10 milligram. However, in addition to CKD, Jardiance is also indicated for cardiovascular risk reduction, especially when you have type 2 diabetes patient with established cardiovascular disease. Then Jardiance play a huge role by reducing CV death by 38% in those individuals, and as well as reducing hospitalization for heart failure by 35%, and then also have a significant benefit in reducing incidence or worsening nephropathy by 39%. So apart from that, if you look at the 25 milligram we have, it's more for type 2 diabetes, where you want an improved glycemic control. So please, I want you to keep these two doses in mind and what they are intended for. The 10 milligram is for CKD. It's also used for cardiovascular risk reduction, and then type 2 diabetes. And then also, last but not the least, it's also used in chronic heart failure. that is, if you look at the spectrum of heart failure, either patient with reduced ejection fraction or patient with preserved ejection fraction, then you need a 10 milligram. 25 mainly for your type 2 diabetes, where you want to improve glycemic control. If we listen to the presentation carefully, both speakers alluded to the fact that we need ACE inhibition in these patients, which is very, very critical. And we know that significant number of these patients usually cannot tolerate the ACE inhibitors because of the dry, persistent cough. But of course, you need to protect their kidneys. We have Mikadis. As we know, we have both strength. We have 40 milligram and then 80 milligram readily available. The 40 milligram, it's indicated for hypertension. So of course, you want to, make use of them, not just to reduce blood pressure in these patients, but again, because of their renal protective effect. Now, the 80 milligram fortunately have two indications, one for hypertension and also cardiovascular risk reduction. So these are the two main class of drugs. If you look at the topics we are actually discussing. So please just take note of that. If you need any further information on these products, our reps are almost every now and then knocking at your door. If you need clinical trials or a lot more clinical data, please, you can liaise with them, or you can send me a WhatsApp message or send me, let me put it that way. We will send you a link where you can share your needs with our medical team, and they will be much more than willing to assist you with any kind of information you need to improve your practice. So Brenda, thank you very much for the opportunity. I think we can move on to the Q&A. Thank you.
Thank you, Jonas, for that presentation. At this point, I'll invite Dr. Pedita to take us through, to lead the Q&A session. And audience, I'll still encourage you to type your questions on the chat box.
So thank you very much, Brenda. I think that these two questions will go to Professor Boima. Prof, at what point do you have to add EMPA to ACE or ARB? That's the first question to you. What point do you have to add EMPA to ACE or ARB? And then the second question.
I think
the other question is, has any study been done in Ghanaian population on SGLT2?
Sorry, I can't hear you, Pedita. Sorry
about that.
I didn't hear the second question, please.
Has any study been done in the Ghanaian population on SGLT2?
No, I think you're breaking. I can't hear you. Can you hear me?
Yes, please.
Any study been done? Oh, so in Ghana population,
yes.
Currently no SGLT2 study has been done yet. Probably in the future that may come true. But the first question, just like I said, and you also alluded to earlier on, SGLT2 is considered in our guidelines as a first-line medication. So as early as you can introduce your SGLT2 inhibitors once it is indicated, even in addition to your ACE inhibitors or ARBs. So somebody with GFR between 20 to 45 with proteinuria of more than 200 milligrams per gram, you can start your ACE inhibitors as early as possible. Somebody with heart failure, irrespective of the level of albuminuria, you can start your SGLT2 inhibitor as early as possible. The main aim here really is to start early to delay progression, not too late when damage is already caused. So, line therapy, you may start the medication when the indications are there, just like I stated in my presentation. The indications are very important, irrespective of the fact that we say that you should use them very early. Or I guess some people start it even when the indication is not there. So we should look clearly at this as the indication. We state clearly here And even the GFR is 20 or more, you can start. If they have proteinuria of more than 30 milligrams per millimole with GFR of between 20 to 30, you can start. Heart failure, irrespective of ammonia level, you may start your SGLT2 inhibitors. So I think we should consult the guideline, look at the indications, and start at the point where the patient may have maximum benefit.
Thank you very much. So the next question, maybe I'll take that. The question was, should we wait 3 months before repeating blood urea, electrolyte, and creatinine? So to address this one, you want to diagnose chronic kidney disease. If you get the definition and understanding of how to label somebody chronic kidney disease, because you know the implication of chronic kidney disease, but we are just lucky that now we have medications like EMPA to slow down progression. But then you want to be careful to label somebody as being a patient with chronic kidney disease. And therefore, you need a lab that has lasted for more than 3 months. So just one-time thing, if you see a patient today, and let's say the creatinine is 200, and your eGFR is, let's say, 30, you cannot just look at the eGFR or the creatinine figure, just one-time thing, and say that, my dear, you have chronic kidney disease. No, you should repeat it in the next 3 months to see whether this is still there, this is still persistent, because we have acute kidney injury, we have spectrum of kidney disease, and one is acute kidney injury, 2 is acute kidney disease, and then 3 is chronic kidney disease. So these are spectrums. And acute kidney injury, the patient can recover if you remove the underlying cause, and the patient will revert back to normal. Acute kidney disease, the patient has moved from the kidney injury limits or period into a stage that the patient still has a kidney disease, so that when you address the underlying cause, he or she may go back to normal kidney function. So within this period, you don't want to label the patient as having chronic kidney disease. That's why there's the need for you to get figures that has persisted for more than 3 months. So sometimes you can even put somebody with acute kidney injury, acute kidney disease on dialysis. You still have to monitor this patient so that after 3 months, if this patient is still dialysis dependent, then you can label this patient as a patient having chronic kidney disease. I hope I've addressed your question. And then the next question was, should we still add ARB or AC if blood pressure is normal? I don't know if Prof will want to take that, or I should address it.
So the whole point is kidney protection. Is there an indication for using this medication? Is there proteinuria? Is there other markers of kidney damage? That's what we need to look at. So in some patients who have proteinuria but normal GFR or maybe relatively good GFR, we still introduce these drugs at low doses in order to reduce the proteinuria and also reduce the rate of kidney disease progression. If you look at the heat map or the table I showed you, when the more protein you have in the urine, the more your risk of progression to kidney failure, the more your risk of cardiovascular disease. So there's still benefit for these patients at these early stages when they have moderate to severe proteinuria, even with GFRs normal or even BPs within normal range. So this is even where, if you are actually worried about giving ACE or ARBs, which will lower your BP, you can use your SGLT2 in order to slow progression of kidney disease among these patients. Monitor them, of course, for initial dip in kidney function, monitor them for drop in BP, monitor them for any other problem that you need to monitor them for. It's very important. Once you monitor them very well, you may detect all these things and even find out that there are other causes of the dip in GFR or probably a drop in BP, other than this medication that you may be using, which probably will help you to stop them. Most of the patients may not be hydrating well. Some of them may be on NSAID, some of them may be taking concomitant herbal medication, and all these things that you need to stop in order to maximize your treatment towards their long-term management.
So thank you very much, Prof. So the next question is, is AC or AR be contraindicated beyond CKD3B into end-stage kidney disease?
So ACE inhibitors or ARBs are actually not contraindicated in any level of kidney disease. What is important really is how you monitor your patients. I think the problem is how erratic our monitoring system at the OPD is, our scheduling system for the patients are. So even in advanced stages where GFRs are less than 10, we are afraid that maybe when they go, they don't come, but the potassium is going to go up. And therefore, we are taking measures to protect them against those things. So some people will use their discretion and stop it, but really, they have other benefits. And we know our patients are at risk of cardiovascular disease. So they will benefit from the ACE inhibitor for heart, they will benefit from the ARBs for heart, they will benefit from the SGLT2 for heart. And as you already saw today, when they are already on the SGLT2 before the GFR goes below 20, you don't stop, you continue. So that's key and very important for you to note. So most of the reasons why people stop ACE inhibitors or ARBs in advanced stages of kidney disease, I think it's purely discretional and not guided by evidence for that matter. So at any stage of kidney disease where there is benefit, you may use ACE inhibitors or ARBs, except in the phase of acute kidney injury, as Dr. Ochi mentioned earlier on. If your patient has acute kidney injury, you would have to suspend this drug temporarily until the acute kidney injury resolves. Then you may reintroduce the drugs again gradually. And I think the same thing goes for the SGLT2 inhibitors as well. If there's significant impairment in kidney function acutely, you may have to suspend these things until the kidney function improves before you reintroduce them again.
Okay, so thank you, Prof. And the next question is, I think the person is asking because metformin is indicative in this scenario.
Sure.
He's saying,
Yeah,
I know the question is, can EMPA be used in obese patients with polycystic ovarian syndrome and pre-diabetic patients? Can EMPA be used in patients who are obese and have polycystic ovarian syndrome, and those who are also pre-diabetic?
Contraindicated in this. Hello, can you hear me?
Yes,
Can you hear me? I don't think
yes,
it's contraindicated in the patients. It's not contraindicated in patients with obesity. It's not contraindicated in patients with pre-diabetes or polycystic. Have kidney or cardiovascular indications for using them, you may use them. If it's control, you may use that by your own discretion, but as per the indications for the heart or kidney as stated here, when the indications are there, irrespective of whether they're obese or not, or have PCOS or not, you may use this medication, or have pre-diabetes, or you may use this medication for them. I've seen people who have that kind of metabolic phenotype, have BMI, say around 35, and sugar is in the impaired fasting glycemia stage, and have proteinuria of say 20, etc. And I introduce this medication and also other drugs that may benefit them in the long term, purely for both the kidney and of course for the glycemic control as well. And I've seen some benefit in these people. In a long term, perhaps if these people develop full-blown diabetes, SGLT2 alone may not be enough for glycemic control. You may have to introduce other medications that will help you to control the blood sugar.
Thank you, Prof. I think this one goes to Jonas. How much is Jardiance 10 milligrams daily for 30 days?
All right. Thank you very much, Dr. Ochi. Currently, Ghana, the price or the cost of Jardiance in Ghana, it's 669 at the wholesaler's end. Once it hits the retail outlets, you are likely to get it around 850, 860. However, I must be quick to add that usually we need to look at the cost of acquisition or buying these medication versus the economic value, of these medication. If you look at it from that perspective, then I must say that Jardiance, regardless of the price I've mentioned, appear to be the most cost-effective medication from pharmacoeconomic perspective. Because if you look at the data, presented by Professor Boima and some of the comments made by yourself, clearly, if you look at the cost of hospitalizing these patients in our, hospital, the cost of dialysis, no patient would like to even think about it. So I would like to, I don't know whether I've answered the question, enough to calm the person down. Thank you very much.
All right, so this one, maybe Prof. Wama may take us through, or Jonas, you can also come in. Is EMPA superior to dapagliflozin?
I don't know whether...
Maybe with respect to cardiovascular events and then kidney events.
All right, so currently, if you look at all the studies, we don't seem to have head-to-head study with these SGLT2 inhibitors. But we have different studies. For instance, if you look at the DAPA-TIMI-58 trial, and you look at, it's more of primary prevention study. However, significant number of these patients fall within the secondary prevention arm. Unlike the EMPA-KIDNEY trial, where you have about 90% of the study population, who appear to have established cardiovascular disease. So it's more or less like a secondary prevention study, sort of. Now, if you look at the outcome, if you just tease or you pull the studies apart and you look at those with established cardiovascular disease, and you look at endpoint like risks of cardiovascular death, there is no significant difference between DAPA and then the placebo in that particular study. However, if you look at the same group of patients with the same prognostic features, they realize that the risk of CV death, or the relative risk reduction is the right word. The relative risk reduction of CV death is about 38%. Now, again, if you look at the data again, and you look at all-cause mortality in the same study as I've mentioned, empagliflozin or Jardiance reduce all-cause mortality by 14%. If you look at the other study, which is the DAPA-TIMI-58 trial, there is no difference between the placebo arm and then the active arm. However, if you look at other benefits like hospitalization for heart failure, renal benefits, then there is no difference between these drugs, except where we are looking at the high risk, those with established cardiovascular disease, where EMPA has clearly demonstrated CV death benefit and all-cause mortality as compared to, DAPA. So that is the evidence so far available. Thank you.
So please, a follow-up. It means, has there been a head-to-head comparison of the two? It's just EMPA placebo, DAPA placebo?
No, so like I said from the beginning, so far there is no head-to-head across all the SGLT2 inhibitors. So we are treating them case by case, and then look at the pool analysis and look at the patient group. Because when you look at the study design, they appear to be similar, but we are then looking at who are those who comes with established cardiovascular disease, who are those that falls within the primary prevention arm. And like I said, if you take the secondary prevention arm, then empagliflozin have shown significant reduction in cardiovascular death as compared to dapagliflozin, and then as well as all-cause mortality. But again, like I said, if you look at reduction in hospitalization for heart failure, and then the renal benefit, then across board, there is no difference between the SGLT2 inhibitors.
All right. Thank you very much. So, thank you.
Dr. Atwe, I think just like Jonas said, the has been no head-to-head comparison, but the comparisons across board for all these molecules have been the effect size compared to the placebo in the various studies that have been done, just like he explained, by how much they reduce each of these events that he mentioned. That's really been the case for now. Just to throw a bit more light on the polycystic ovary syndrome thing, you know, they tend to have weight problems and all that. So we know that SGLT2s can actually reduce body weight and fat mass and improve metabolic markers. So again, if we use them in these patients, they may actually end up benefiting from it. Hello, can you hear me?
Yes, Prof.
Okay.
Yes. Thank you very much. So I think we don't have any more questions at the moment, so I'll hand over to Brenna. Thank you.
Thank you, and thank you once again for that engaging presentation and insightful meeting as well. Thank you, Professor Boima, Dr. Pedita, the CS team, our wonderful audience. You have stayed till now, and also the questions, I believe they have been adequately answered. I also like just to point out to you that our representatives are from Boehringer and DP World will be visiting you in your clinics to further this discussion. At this point, I just want to thank you once again and wish you a lovely evening.
Hello?
Yes?
So, okay, so at this point, we want to say thank you to everybody. And we want to say that this is the official launch of empagliflozin for kidney disease in Ghana. And as you have seen the overwhelming evidence and its presence in our guidelines, we want to say that officially EMPA is launched as an indication for CKD treatment in Ghana. Thank you very much.
Thank you, Professor. Unless there is a comment from the CS team regarding the points, CPD points. Otherwise, I wish you a lovely evening.